Good morning, ladies and gentlemen. I would like to present my presentation. My main topic is systematic treatments of metastatic prostate cancer. My name is Anikó Valikovics. I work as a doctor in Semmelweis University in Department of Urology. My supervisor is Tibor Szarvas. My SMS is Isabella Mórim. My vision: patient will have the best treatment option for metastatic prostate cancer, and my mission to find a drug that significantly improves the quality of life of patient. We have got two specific goals. The first project, we focused the abiraterone and the enzalutamide treatment in metastatic prostate cancer patient. We started this project in last year in September. And the second project, we focused the PSMA radioligand therapy. This project we started the last year in November. The first project, investigating the efficacy and safety of abiraterone and enzalutamide in patients with metastatic prostate cancer. The prostate cancer is the second most commonly diagnosed cancer. More than 1.2 million new cancer cases, and the mortality is more than 300,000 diseases in 2018. The metastatic prostate cancer, it is the late stage, and the median overall survival of 30 or 35 months. The abiraterone and the enzalutamide, it is a standard treatment in metastatic castration-resistant prostate cancer, and it is both similar androgen receptor signal inhibitors. The indication and the mechanism of action are similar, but unfortunately, we haven't got clinical trials available for the direct comparison of their efficacy. The aim to investigate which of these two treatments is more effective in metastatic prostate cancer. We have got a clinical question, this project: which treatment is more effective, abiraterone or enzalutamide for metastatic prostate cancer? We stand the PICO. The population is metastatic prostate cancer patient. The intervention is the enzalutamide, and the compliance is the abiraterone. We have got two outcomes. The first outcome is the overall survival. The second outcome is the PFS, the PSA50, and side effects. The hypothesis: the enzalutamide is superior to abiraterone in patients with metastatic prostate cancer. The clinical implication: increased therapy efficacy in metastatic prostate cancer patients. The preliminary research, we have got only one domain. We used 3 databases: PubMed, MBase, and Cochrane, and after we have got 9,490 results. We finished the search in mid-November the last year. After the duplication, we haven't got 7,138 papers, and after the abstract and title selection, we have got 186 papers, and after the full text selection, we have got 44 papers. The first project progress, we have got a feasible topic. We have got a Prospero registration, we finished the duplicate removal and the title abstract and the full text selection, and we finished the data extraction. And now we will start the ROB and the figure and the table part. The next slide, I would like to present a bit results. The PSA50 response to abiraterone and enzalutamide in metastatic prostate cancer patient. The PSA50 mean that the PSA is declined the 50% or more. This slide, we see 15 articles. These articles, it's a retrospective cohort studies, and we see the first and the second line settings. We see two groups, the enzalutamide group and the abiraterone group. The enzalutamide group, we have got 1,783 people, and the abiraterone group, we have got 1,858 people. And we see that the enzalutamide is more frequent than the abiraterone, and the odd ratio is 1.91, so it means that the enzalutamide is effective 91. The heterogeneity is high, and we can ask that it is a mathematical significant and clinical important. The second slide, we see the first line setting and the second line setting. We see that the first line setting, we have got 11 articles, and the odd ratio is 1.74. and the second line, we have got 5 articles, and the odd ratio is 2.21. These 2 slides is big heterogeneity. The second topic, the identifying patients with metastatic prostate cancer who benefit from PSMA radioligand therapy. The epidemiology is same that the first topic. The treatment option for metastatic prostate cancer rapidly expanding. The prostate-specific membrane antigen, it is a transmembrane glycoprotein overexpressing in the high-grade advanced prostate cancer. The PSMA radioligand therapy is a new treatment for metastatic castration-resistant prostate cancer, which combines the PSMA antibody with different radionuclide, including beta emitters such as lutetium-177. The clinical parameters for PSMA radioligand sensitive patients need to be identified. The aim to identify the clinical and pathological parameters defining the most responsive patient to PSMA radioligand therapy. The clinical question, who do different clinical parameters influence the outcomes of PSMA radioligand therapy in metastatic castration-resistant prostate cancer? We send the PICO, the people, it's the PSMA radioligand therapy patient. The C is the echo, the age, and the metastatic localization, and we have got 2 outcomes. The first outcome is the overall survivor, and the second outcome is the PFS, the PSA50, and side effect. The hypothesis, the PSMA radioligand therapy provides greater overall survivor in advanced metastatic castration-resistant prostate cancer patients with specific clinico-pathological characteristics. The clinical implication, PSMA radioligand therapy may be more widely used in advanced metastatic castration-resistant prostate cancer. The preliminary research, we have got a population domain. We used the same databases than the first project, the PubMed, the MBASE, and the Cochrane. And finally, we have got 2,641 results. We don't see meta-analysis, and we don't see Prospero registration. This slide, I would like to present the 3 key articles when we see that the population is same, that the metastatic castration-resistant prostate cancer patient, the comparison is same, that the echo, age, and metastatic localization, and the outcome is the overall survivor, and the outcomes time is very similar. Finally, I would like to summarize my 2 topics. The first topic, we would like to see the enzalutamide and the abiraterone treatment. And the second topic, we would like to see the PSMA radioligand therapy. And we would like to finish these 2 projects this year, autumn or winter. Finally, I would like hand in eyes that everything is theoretically impossible until it is done. Thank you for your attention.
Both of these treatments are available for the Hungarian patients?
Yes, in Hungarian patient we can use the abiraterone because the enzalutamide is unfortunately it's more expensive than the abiraterone, but this year hope we will see the enzalutamide genericums, and after I think the enzalutamide will be cheaper.
And what is the price difference? So is that so much significant?
In Hungary, money is big.
Mm-hmm. Thank you.
Just a short remark and 2 questions. In your first project, you are assessing causality. So you mentioned that if enzalutamide is superior than abiraterone, you have mainly retrospective papers, because as I know there are no head-to-head comparisons of the 2 except 1 paper. But based on this, you must not use causal language because you can only say that this or that treatment was associated with longer survival or higher rate of treatment response. But it's when you are writing your manuscript and using this causal language in case of retrospective trials, then the reviewers will point it out, and it's not correct, like methodologically. But this is a minor thing which you should take into consideration when you will write. The second is that these are really exciting results, and when you were showing the PSA 50 response rates in the second-line treatment, do you have any specific subgroup analysis based on the previous treatment? Because you know the efficacy of Abi or Enza after the other, it can be different or hypothesized to be different. Could you assess this during your analysis?
Yes, we see that the continental subgroup, that which continent it's better the second line in the abiraterone and the enzalutamide. And we see that we have got a metastatic castration-resistant prostate cancer patient, and we have got the metastatic hormone-sensitive castration patient.
And for the second study, it's really timely, really relevant. Be fast with it, because I'm sure that many groups are on this same topic, despite they don't have Prospero. And there are more and more RCTs, and the highest quality of data you can get from RCTs, especially for these effect modifiers. Could you include, or did you find any key RCTs? I think there are 3 or 4, another 2 are coming extra, and every oncology congresses, or only retrospective again?
Only retrospective studies.